coming to the indications of renal biopsy, which is being there. So what are the indications of renal biopsy when you are having an acute renal failure of unknown etiology? The second is if you are suspecting a glomerulonephritis with systemic disease. So a renal biopsy in such incidences or cases may provide the basis and justification for life-saving therapy. Like if you want to give high-dose steroids, cytotoxic agents, if you want to go for a plasmapheresis. And if acute tubular necrosis is not recovering after 4 to 6 weeks of dialysis with no more recurrent insults. So a renal biopsy at that time may determine a less favorable condition, such as diffuse cortical necrosis that has developed, and that chronic hemodialysis may need to be instituted. So acute kidney injury, we have already discussed pre-renal cause. We have discussed the renal cause, intrinsic ATN, post-renal surgical treatment. Because there is an obstruction, you need to correct it. Pre-renal, of course, hypovolemia, if it is being there, correct it. Euvolemia, give a fluid challenge to the patient. If the patient improve, very good. Patient not improved, think of an ATN. If it is an ATN, hypovolemia patient, because ATN due to hypovolemia, give fluids, correct it. If it is a euvolemia, give fluid challenge, improved, very good. If it is a hypervolemia, you need to wash out the excess fluids, give a diuretic. Improved, very good. Not improved, then go for a dialysis of this patient. So the mortality rates among the patients with acute kidney injury approximate almost 50 to 60%. But it should be stressed that patients usually die from sequelae to the primary illness, not from the acute renal failure itself, because of the complications we discussed that happens due to AKI. So mortality is affected by both severity of this disease and the clinical settings in which this ARF occurs. So the mortality of ATN is 60% when it results from surgery or trauma, 30% when it occurs as a complication of medical illness, and 10 to 15% when the pregnancy is being involved. Ischemia associated with acute tubular necrosis that has 2 times the mortality risk of nephrotoxic ATN. And in agreement with this interpretation, mortality rates vary greatly depending upon the cause of acute renal failure. That is almost 15% in obstetric patients, 30% in toxin-related ARF, and 60% following the trauma or major surgery. Oliguria at the time of presentation or rise of serum creatinine greater than 3 mg per deciliter or associated with a poor prognosis reflects the severity of the renal injury and the primary illness. So mortality rates are higher in older elderly patients and in those patients who are having a multiple organ failure. So this we are discussing the prognosis of the AKI patients. So patients with no complicating factors who survive an acute episode of acute renal failure have a 90% chance of complete recovery of kidney function. Very important. So this is the prognosis of this patient. Let us discuss the case which is being linked to this current discussion which we discussed.